As most of you know, vertebral augmentation has been something that I've been involved with for a long time. It's been a passion of mine for a long time. And we're going to discuss the pros. In the spirit of disclosures, I do have relationships with each one of these listed entities up here. When we're talking about vertebral compression fractures, it's really about biomechanics. There's been a lot of debate as to whether it's pain, whether it's the structure, but we're really talking about biomechanics, how to keep the spine tall, straight, and how to augment the vertebral bodies so that we maintain the overall alignment of the spine. We know that kyphosis begets further kyphosis. If you sustain a crack in a vertebral body, we know that the resultant forces are exaggerated. You get force transmission to the level above and below, and you get propagation of the kyphosis. And this is really what we're trying to avoid. We're trying to avoid this leaning tower of Pisa phenomenon in our patients. We know that alignment is critically important. It does affect function. It affects function in many ways, but it also predisposes to further issues down the road. So the biomechanics of kyphosis, again, there's normal load transfer through the vertebral body, comes through one end plate, through the centrum of the body, and then through the shell surrounding the body down to the next end plate. But if you've got an osteolytic or an osteoporotic process, you load that vertebral body, there's very little substrate really in the center of the vertebral body to transfer those loads. So you get load transmission to the shell of the vertebral body down to the next level. And that's where the vulnerable segment becomes. And there's been a lot of basic science work looking at the fact that kyphosis begets further kyphosis. And we've published a number of these papers looking at strain at the apex, looking at the adjacent vertebrae, which is at higher risk for fracture, defining how much cement you need to augment that vertebral body to normalize the load transfers. We know that increased centrum load transfer while increasing strength reduces that stiffness of the vertebral body. So these are all things that we've studied over the last number of years on this. Now, vertebral augmentation has been around for quite some time. We know about vertebroplasty and kyphoplasty, and essentially it's a spectrum, but we shouldn't consider these things one or the other. They're not mutually exclusive. What we need to do is think of these as tools and use them at the right time for the right configuration. So if you've got a stabilization procedure, you can just fill the vertebral body with cement. If you've got to reduce or reconstruct, you do some kind of kyphoplasty procedure where you're recreating that vertebral body. Now, if you go through the literature, and this was a PubMed literature search, and this I just did a couple days ago just to update this. The first vertebroplasty paper was published in March of 1985. The first kyphoplasty paper was in July of 2001. But since then, there were 2,942 papers published from 1985 to June 2014. That's 8.5 papers per month. I would maintain that this is probably one of the most studied areas that we've ever done in spine surgery. And this, I think, is one of the pros. One of the benefits is all the information that we really do have that's out there on this. And what I've done is picked what I think are a few of the landmark, the important papers for us to really know about. You've got Wardlaw's paper with 300 patients, 1 to 3 vertebral compression fractures. This was a randomized trial to non-surgical treatment. And we will talk about the difference between some of the other trials that have been out there. But this is really level 1 evidence validating the benefits of kyphoplasty early in the treatment of compression fractures. For acute vertebral compression fractures, kyphoplasty is more effective than non-surgical care. And there was really no difference in the frequency of adverse events. And when you look at subsequent fractures, you see there was 33% in the kypho, 25% in the non-surgical group, which was a non-significant difference. This is a paper by Clazen that was published in The Lancet. This was a vertebroplasty paper versus conservative treatment in acute osteoporotic compression fractures. This was an open-label randomized trial. Again, a lot of patients, 200 patients overall were in the study, 101 vertebroplasty, 101 to conservative treatment. And here again, they concluded that in patients with acute vertebral compression fractures and persistent pain, percutaneous vertebroplasty is effective and safe. The pain relief is immediate, it is sustained, and it is significantly greater than that achieved with conservative, non-operative measures at a very acceptable cost. We've also got another paper by Farocchi et al. From Neurosurgery Spine. 105 patients randomized. 40 underwent vertebroplasty, 42 went optimal, what they called optimal medical management. They followed them up out to 36 months in this group. And again, the percutaneous vertebroplasty group had statistically significant improvement in the visual analog quality of life scores, and the vertebral body height was maintained out to 36 months. So this is all evidence about the pros, the benefits that we have of vertebral augmentation. Now, this was an interesting paper published by Edden in Journal of Bone and Mineral Research, where they looked at a database from the United States, looked at the Medicare database from 2005 to 2008, and they pulled out all the patients that had vertebral compression fractures, and of that subgroup took the ones that underwent a vertebral augmentation. And what they found is that vertebral augmentation group were 37% less likely to die. They had a higher survival rate of 60% versus 50%. So again, this is another pro. We are changing the lives of our debilitated patients with these compression fractures. So it's very important to keep all of this in mind. Now, a couple years ago, 2 papers were published in the New England Journal of Medicine. And these papers have been scrutinized, and they came out with a lot of fanfare. But the reality is they've now been discredited, essentially. I'm going to show you some of the things about this. This is the paper by Calmes et al., 131 patients, 13 centers, vertebroplasty versus sham. They only had 1 month follow-up, and they concluded that improvements in pain and pain-related disability associated with compression fractures in patients treated with vertebroplasty were similar to the control group out to 1 month. So they really didn't show a difference, but remember, 1 month. This is the sister paper that was in that same journal by Bookbinder. 78 patients, 4 centers, again, vertebroplasty versus sham. Everybody was out there saying that we can't just do against non-operative, we have to have a sham procedure with it. Well, so there's these 2 papers that came out, and they also found no beneficial effect of vertebroplasty compared to the sham procedure at 1 week, 1, 3, or 6 months. But again, they really weren't doing a sham procedure. They were still taking these patients to the operating room. They were injecting local anesthetic. They were putting other medications in place. It was still an intervention. The 2 papers, the follow-ups were very short. In neither paper did they define the acuity of the fracture that they were dealing with. So here is really the critique of the Bookbinder paper. There was a lot of selection bias. 78 patients enrolled out of 468 potential patients, of which 25% were excluded because they didn't even have a fracture. So you got to question the quality of their diagnosis. What's the origin of the pain? Their 12 months in presence of 1 or 2 recent vertebral fractures was really their inclusion criteria, and you really don't know, is the pain coming from that? And then you have to question the quality of their intervention. They had 9.5 cases per center over 54 months. That means 1 case, less than 1 case per month per center in this study, which really doesn't make much sense when you're talking about a randomized control multi-center study. And then there's also this fill issue. They were filling on average 2.8 cc's of methyl methacrylate, but their protocol required 3 to 4 cc's. So many things that makes you sort of wonder about that study. This was Calmes' study, and again, this is the critique of that. Again, selection biased, 131 patients enrolled out of a potential 1,813. Because enrollment was so poor, they decided to drop the pain threshold so they can try to get more patients into it. Again, you've got to look at the quality of their diagnostic ability. 11% of their patients had no fractures, so how are they being included in the first place? And 404 patients were excluded, but they really didn't report the reason. And here again, the quality of intervention issue. There was no mention of cement volume, and 43% crossed over sham to vertebroplasty. Now, I'm not much for conspiracy theories, but in the United States, we kind of thrive on that kind of stuff. But if you look at it, the papers I showed before, the Lancet is publishing positive papers on vertebral augmentation. The New England Journal is publishing negative papers. And you kind of wonder, are these guys doing something? Are they trying to further their own separate agendas when we're looking at what we are trying to do with our patients? So here's a couple other important papers that I think really highlight the pros of vertebral augmentation. This was a correlation between preoperative pain duration and percutaneous vertebral augmentation. And just with a little bit of irony, look who one of the authors is. It's Calmes is the other author on this. But they came through and said the age of fracture has minimal impact on outcome following single-level vertebroplasty, with good outcomes noted among patients with acute, subacute, and chronic fractures. So 2 months before, in the Lancet, Calmes is saying he's not seeing any benefit, and now all of a sudden he's providing us a pro paper that's saying, yeah, it doesn't matter if it's acute, subacute, or chronic, we're still getting good outcomes with these patients. Here was another paper by Boonin et al., which is a retrospective controlled study, and this was done by the CSA Fracture Working Group of the International Osteoporosis Foundation. So if you don't want to believe all of the individuals that are intimately involved in doing this on a day-to-day basis, here's an independent group looking at all the randomized controlled trials that were there, assessing them, and they came up with the conclusion that vertebroplasty and kyphoplasty are generally safe. They provide quicker pain relief, mobility recovery, and in some cases height restoration when compared to non-operative management. And they suggest that physicians should be aware of the benefits, the pros of vertebroplasty and kyphoplasty to their patients to reduce health impairment. So what are the pros of vertebral augmentation? VCFs, vertebral compression fractures, we know have a significant impact on the quality of life of our patients. We've shown in the literature, and a lot of us know clinically, that these procedures do help. The outcome shows improvement compared to non-surgical management. And that's really what our comparison is. We're either putting them in a brace, keeping them in bed, giving them medications, or doing a procedure on them. But we're not taking them to do a sham procedure. So it really makes no sense to dictate that we have to compare to that. The outcomes of controlled vertebroplasty studies are still mixed, but I showed you a couple papers that are coming out that really do help support it. Remember that vertebroplasty and kyphoplasty are different procedures, but they're on that same spectrum, so we can use them. And one vertebral fracture configuration may be best treated by vertebroplasty. The second may need more of a kyphoplasty type procedure. But there's plenty of supportive safety and effectiveness data for both of these that I think we still have to study. We still have to look at it closely and really do the best we possibly can for our patients. But there are issues, and to be fair, I don't see anyone on the agenda really talking about the cons of this. We still haven't defined the indications. Are we dealing with pain or deformity? I started this talk by saying treating VCFs is about biomechanics, and that's been my philosophy throughout. Keeping the spine straight, tall, doing the number of levels at one sitting is another issue. We still don't know what the appropriate number is that we can do safely. The approach all depends on how we want to get to the spine and the fracture configuration. I'll be talking Friday a little bit more on using this technology for tumor work. The bone void filler is going to depend on bone biology, on the patients. Right now, polymethyl methacrylate is our friend. We know what it can do, we know what it can't do, but other bone substitutes will be around soon. And then there's always this risk of fat emboli and PMMA monomer getting into the circulation. So I just want to show this one quick case. This is a 61-year young female, and you can see her DEX is minus 4.5. She's already broken both her hips. You can see the progressive collapse. I treated her index collapse, but she just kept getting worse and worse, and went ahead and ended up doing multiple vertebral bodies on her. Now you can see this is from 2012. I see her every 3 months. She hasn't collapsed any further. She is still teaching as a school teacher. So I have no doubt that we've changed the natural course in this lady's life. So one thing that I'll leave you with, it hurts to admit when you've made a mistake. However, when the error is big enough, the pain only lasts a few seconds. So this whole business about discounting vertebral augmentation because of the 2 papers that came out, I think was a big mistake. And with that, we can move on with the rest of the agenda. Thank you very much.